Hello, I'm Ralph Rodino from the University of Pennsylvania, and I'd like to welcome you to the roundtable discussion regarding the late-breaking and recently released trials at the American College of Cardiology meeting that took place in March in Orlando, Florida.
Hi, my name is Naomi Botkin. I'm an associate professor at the University of Massachusetts Medical School.
Hi, I'm John Vivalli. I'm an interventional cardiologist at the University of North Carolina. I'm director of the Structural Heart Disease Program, and I have a particular interest in valvular and structural heart disease.
This is Vicky Bosco, professor of medicine, director of Winter Center for Heart Failure Research, and associate director of Cardiovascular Research Institute from Baylor College of Medicine.
Well, I think one real lesson from the late-breaking trials is that heart failure research is really on the move. And I'd like to ask you, Beacom, what did you think? There were very many studies that were released at the meeting. And tell me which ones you thought were specifically very important studies and studies that would have some clinical utility for our users.
Sure. I think we have seen a growing excitement both from the prevention to the advanced treatment strategies and monitoring in heart failure. So I think we straddle both the very advanced NYHA class 3 and 4 heart failure patients, and in that realm, we did have the long-term results of the Momentum 3 trial. And in regards to being able to monitor patients remotely, we also had very exciting results from the real-world comparative effectiveness study with pulmonary artery pressure sensor study. We also had interesting prevention study results from preventing chemotherapy-induced cardiomyopathy and whether we could prevent decline in LVEF with chemotherapy in breast cancer patients, and whether treatment with beta blockers or ACE inhibitors would be preventive. And I think we also had interesting results, though not earth-shaking, not practice-changing, regarding heart failure with preserved EF and some different routes of treatment strategies such as inhaled inorganic nitrate therapies. So I thought we had a full spectrum of studies, and we of course have also interesting results from the SGLT2 inhibitors in the cardiovascular venue, some of which are primarily targeting prevention of heart failure, and some of them are targeting treatment in high-risk patients, and heart failure is one of the endpoints included in combined endpoints in those studies.
From a practical standpoint, what do you think the cardiologist should do for patients who are receiving chemotherapy? Certainly some of our patients are seen by cardio-oncologists, but a lot of patients out there who do receive chemotherapy for a wide range of conditions are really seen primarily by their cardiologist. So what did this meeting show us that would be of use in treating these patients?
So I'll first talk about what we heard at this meeting. We heard about 2 randomized clinical trials, which both of were, I think, complementary and interesting, and I think are going to be very useful for our cardiologists. One was a study from Brazil. It was called the CHECI trial, looking at the role of treatment with carvedilol in patients treated with anthracycline-based chemotherapy in HER2-negative breast cancer patients. And they preemptively treated patients, and they randomized, of course, this was a randomized study of carvedilol versus placebo. And they were trying to determine whether this approach would obviate or result in prevention of the decline in EF. And their primary endpoint was prevention of a more than 10% reduction in LVEF. They couldn't demonstrate any difference between carvedilol versus placebo in that EF measurement at 6 months. I think from that perspective, it was a bit disappointing. But the interesting finding from this study was they had secondary endpoints of looking at troponin I levels, and the patients treated with carvedilol had lesser patients treated with carvedilol had troponin I elevation compared to placebo. And also, when they examined the patients with diastolic dysfunction, patients treated with carvedilol had lesser incidence of diastolic dysfunction at 6 months compared to placebo. We can interpret these results probably in threefold fashion. One, the EF changes, as you know, vary a lot, and maybe the 10% change at 6 months, maybe inability to detect could have been due to being underpowered because the study was small. I think they enrolled about 190 patients. Second, if they had continued the study longer, perhaps could have seen a difference. Third, they use a small dose of the carvedilol. Most of our cancer patients are unable to be optimized on doses, and thus they couldn't reach the target doses that we're used to in established heart failure patients. But interestingly, one then looks at the troponin I levels and says maybe there is a subgroup of individuals who are prone to these chemotherapy cardiotoxicity, and if we were to use perhaps surrogates or biomarkers and treat those for prevention, meaning monitoring troponin I. And there's a growing field in practice in cardio-oncology of looking at high-sensitivity troponin I and or other biomarkers. In this study, they didn't see a difference in BNP, but they saw that carvedilol-treated patients had lesser patients with carvedilol treatment had a rise in troponin I. And then the other important factor is that diastolic dysfunction could be a early change than EF, and perhaps strain measurements and other imaging modalities may be a little bit better than just looking at the crude EF. The other study was also interesting. That was looking at trastuzumab treatment and HER2 positive cancer patients, breast cancer patients, and it had 3 arms, treating with lisinopril versus carvedilol versus placebo. Again, prevention of decline in EF. And interestingly, they did not demonstrate any difference with lisinopril or carvedilol when compared against placebo to prevent a decline in EF. But when they strategized their analysis by looking at those who had received anthracycline, so not only the trastuzumab but anthracycline, in that group, in that stratified analysis, carvedilol or lisinopril was better than placebo in prevention of the decline in EF. So overall, one can look at the concept as a glass half full concept, meaning in high-risk patients, because combined chemotherapy with trastuzumab and anthracycline always is associated with worse incidence of cardiotoxicity. And in those patients, either strategy of beta blockade or ACE inhibitors in this trial seemed to work. Though this was a secondary analysis, it was not the primary endpoint, it's still, I think, promising. The second study from Brazil demonstrating a decline in the troponin I levels, I think is promising, maybe implying that targeting therapies to those individuals who elaborate certain biomarkers may be a way of targeted prevention, but needs to be tested in larger studies. In clinical practice, I think the general cardiologists, in alignment with cardio-oncologists and heart failure specialists, definitely need to be in a good communication to individualized therapies, because the dosing, as you know, for anthracycline matters. In HER2 receptor positive patients, trastuzumab, when combined with radiation therapy and or anthracycline, is associated with a higher incidence. So I think we need to know exactly which patients are high risk, which doses are high risk, monitor these patients closely, know when to do their echoes, when and if there's a decline, definitely seek consultation and or guidance. Beta blocker ACE inhibitors in high-risk patients so far seems to be promising, either as a prevention strategy in very high-risk patients, especially in anthracycline treatment, or in individuals with established LV systolic dysfunction or history of heart failure. And mind you, these studies were not patients with heart failure. These were prevention strategies.
Great. I also think we got some information regarding heart failure in patients with preserved ejection fractions. I know that's always kind of a difficult area to treat, and there really aren't that many therapeutic modalities. But what did we learn from the ACC meeting regarding the treatment of these types of patients?
So we had one study which was quite interesting. It was called the INDI trial, looking at inhaled inorganic nitrite treatment in HFpEF patients. For those ones who will remember, in the last couple of years, we've been looking at nitrate therapies in heart failure with preserved EF patients. We, a year or two ago, had the results of the NEAT trial. This was before this ACC, looking at the role of isosorbide mononitrate compared to placebo in HFpEF patients. This was an NHLBI-sponsored study. That was nitrate, oral nitrates, and failed to demonstrate any improvement in exercise capacity and overall combined endpoints in HFpEF patients. Now, this one is looking at inorganic nitrite in an inhaled fashion. And they gave the inhalers 3 times a day. The concept is the inorganic nitrites, which is when broken down, will have an impact on the nitric oxide pathway and may have a favorable effect on the vascular endothelium as well as the diastolic function and overall relaxation of the ventricle. And this concept was, supported by preliminary studies. So this was the randomized study to determine whether in approximately 100 patients with HFpEF would benefit from inhaled inorganic nitrite treatment. It failed to demonstrate any efficacy, and it was criticized partly because nobody could ascertain in the discussions that ensued whether the inhaled therapy had the appropriate bioavailability that was envisioned or targeted, because there was no plasma levels or the byproducts measured. And also there was a discussion about, oral forms, because there's now a big debate about beet juice, providing similar beneficial effects. And there is data with exercise performance with beet juice, which does provide the inorganic nitrite. And thus, people were debating whether one should give up the concept of testing the inorganic nitrites in HFpEF patients, or whether we should retest this concept with assuring bioavailability and making sure that the circulating byproducts are at adequate levels, and or looking at characterization of exercise performance, which was the main target of this study, is also supported by other measures such as hemodynamic measures and or biomarkers. I think the concept of nitric oxide or downstream signaling or cyclic GMP concept cannot be thrown out yet in the HFpEF world. But we, of course, are always humbled by lack of benefit in HFpEF studies, maybe not targeting the HFpEF phenotype as a combined group and trying to perhaps come up with specific treatment strategies for subgroups in HFpEF, maybe another potential promising strategy. Because right now we're treating every heart failure patient with preserved EF as if it's the same pathophysiology and or the same perhaps target. Probably knowing that we failed to demonstrate an effective treatment strategy, either in terms of mortality or surrogate outcomes in the HFpEF world, we are now starting to think back and say, shall we create more individualized therapies to different subgroups or subphenotypes of HFpEF? Not every HFpEF is the same. Hypertensive heart failure is different than others.
John, I think there were several interesting studies regarding interventional cardiology. What was your take on these studies and the meeting?
Yeah, unlike in recent memory, the TAVR trials really didn't dominate the late breakers this year as they have in recent years. And we're all awaiting the results for the low-risk TAVR trials, and we think that'll come at next year's ACC. But there wasn't a lot regarding TAVR in particular at this year's late breakers, but there was still a lot regarding structural heart disease in general. One of the late breakers that was presented I found really, really interesting, and it relates to heart failure, and it continues to demonstrate that the fields of interventional cardiology and heart failure are continuing to merge in some ways and continuing to work together. There was a study evaluating this new device that creates an interatrial shunt. It creates a one-way shunt from the left atrium to the right atrium as a way to reduce left atrial pressure, as a way to improve symptoms for heart failure. As we know, a lot of the symptoms from heart failure are due to elevated left-sided pressures, left ventricular diastolic pressure, left atrial pressure, and we use medical therapy in large part to help reduce the left atrial pressure to treat symptoms. But this company's come up with this device called the V-Wave, which is inserted percutaneously, and it's basically a one-way valve that allows shunting from the left atrium to the right atrium to reduce left atrial pressure and improve symptoms. And this was a first-in-man study that evaluated just 38 patients, but they included both heart failure with preserved ejection fraction as well as heart failure with reduced ejection fraction. And they evaluated the efficacy and the safety of this device in this first-in-man study. And they showed that it was a safe device, could be done with minimal complications. There was one episode of tamponade in one of the 38 patients, but otherwise appeared to be a safe device and a device that was relatively straightforward to put in. But it demonstrated, really interestingly, improvements in New York Heart Association class, quality of life, and 6-minute walk distance, all things that are very meaningful to our patients. And so this is very early, and I think this is sort of a peek into the future of what might come. But it's very exciting for us in the interventional world that we may have a therapy coming that may allow us to treat patients with heart failure with reduced ejection fraction and heart failure with preserved ejection fraction as a way to improve symptoms by reducing left atrial pressure.
Great. Does anyone else on the panel have any opinions regarding that study in particular? Okay, if not, John, were there any other interventional studies that you found would have some clinical utility for the practicing cardiologist?
There was a study evaluating the real-world efficacy of ambulatory PA pressure monitoring. And this was a study that used Medicare data to evaluate Medicare heart failure patients who had PA pressure monitors implanted, and then compared it to real-world controls, like controls who didn't have PA pressure monitors. And it was a retrospective study looking at things like all-cause mortality and heart failure hospitalizations at 12 months. And it showed that, at least in this study, the group that had the ambulatory PA pressure monitoring seemed to have improved survival and reduced heart failure hospitalizations. Now, I think you have to take this all with a grain of salt. This was not a randomized study. This was a retrospective analysis. And as we all know, patients who come in for devices like ambulatory pressure monitors tend to be more engaged in their healthcare, maybe in general a little bit healthier population. And so it's hard to know that we're directly comparing apples to apples. They did their best with statistical analyses to find a cohort that was very similar and was matched in some ways. But I think for those of us who are involved in implanting ambulatory PA pressure monitors, we know that it helps us keep closer tabs on patients. We think it reduces hospitalizations for heart failure, and that at least allows us, in a more detailed way, fine-tune medical therapy in an ambulatory setting.
Great. Naomi, what did you find most interesting from the late-breaking trials, and which studies do you think have some clinical impact in going forward?
Sure. So, as a general cardiologist, I rotate in the CCU, I do clinic work. So, I was very interested in looking for trials that would potentially have an impact on the general cardiologist, both in the inpatient and outpatient setting. I would say that one of the ones that I think was the most impactful was the VEST trial, and it was a disappointing trial to me because, as someone who takes care of patients in the CCU and a lot of new patients with large MIs and an ejection fraction that's low, sending them out and crossing my fingers that nothing happens to them before they get a chance to either have a recovery or EF of their EF or an implantable defibrillator, I was disappointed to see that there actually was no benefit to the wearable vest. It's the wearable defibrillator, and there was no improvement in there was no decrease in sudden death or arrhythmic death. Interestingly, one of the things they did find was that there was improvement in all-cause mortality, and this was not related to arrhythmic death. So most likely this reflects the fact that the patients who were wearing the vests were more engaged in their medical care. Perhaps they were more serious about taking their medications. They had a constant reminder that they needed to be watching their diet or engaging in exercise or what have you. So I think that probably tells us that we have a long way to go with finding ways to encourage our patients to engage in their own health care and improve their post-MI care, because there's a lot that they can do themselves, but we don't have to put on an expensive vest in order for them to be able to do that.
Yeah, I think the results really are very interesting. I think mortality is really what we're looking for to show a benefit of that. And this study actually did show that, even though it technically wasn't the primary endpoint. Most interesting, it was actually the primary endpoint at the very beginning or when the study was planned. But, most people actually thought, gee, even just showing a significant improvement in sudden death. It's actually very much the reverse of implanting an implantable defibrillator early post myocardial infarction. So the studies, the IRIS study and the Dynamite study, showed a significant decrease in sudden cardiac death with the implantable defibrillator, but no significant improvement in total mortality. So maybe it changed the way that people died. And obviously, the regulations from Medicare and the guidelines that say that we should not implant devices for at least 40 days after an infarct or 90 days after an intervention really are based upon those studies that showed no improvement in overall mortality. The vest in the study did show a significant decrease in mortality post-MI. So I think we need to maybe wait to see a little bit more of the study. Again, a late-breaking trial benefits from the hype of the study, but also maybe suffers the presentation a bit because all the data were not really analyzed at that time. So probably my impression is a little bit more to be seen on that. Does anyone else have any impressions regarding the study as well?
I think another real important lesson from the VEST trial was that on average, the patients who were randomized to wearing the vest only wore it about 14 hours per day. And as we know, patients in general perform better and are a little bit more compliant in clinical trial settings than they are in the real world. So, you really wonder how often and how much these patients are really wearing it out in the real world. And this is advice if you're wearing it. And if you're only wearing it 14 out of the 24 hours a day, it's only going to work so well.
I think that's a really good point. But the early studies from the manufacturer's database regarding thousands of studies actually showed that patients did wear the device. Remember, that is all, that data is obtainable very easily. You can hear from the manufacturer. In fact, if you prescribe it and your patient's not wearing it, you call the patient and they call the prescriber. And I'm not quite sure if that was exactly done in this study. So, and actually, again, the results are quite different in the sense that people who wear the vest early on, at least from the manufacturer's data early on, showed an increase, and it was something like 21 hours, and it even increased to 22 hours into several months. So there's a bit of a discrepancy there, and I think we need to learn a little bit more about that as well. But I think you're absolutely right. If people are not wearing the technology, then it's probably not going to work.
I was intrigued by the changes in both the symptoms of dyspnea being less in the patients wearing the defibrillator device, implying Naomi's hypothesis that maybe awareness and compliance was different. But also, I don't think this was not a blinded study. Therefore, probably the providers also had a different approach. Maybe the up-titration of the treatment and or guidance on regimen were different, and or the patient compliance were different. So not being blinded, I think both from the patient perspective as well as from the provider's perspective, creates the question mark. Mike, also, interest will be to find out exactly the types of shocks, the number of shocks, because the data that was portrayed, 14 out of the 20 who received the appropriate shock survived. What did the 6 out of 20 who received the appropriate shock die of? That's very interesting, because what happened to those individuals, and the adjudication for sudden cardiac death or VT-related death is an interesting concept. If that's not the salvage by this device, what was the all-cause mortality reduction due to? Is it due to reduction in heart failure death with the optimization of heart failure therapies due to increased compliance because their dyspnea was less? Or did we have an issue with the adjudication of the endpoint and called arrhythmic death something else? Because it looked like it was effective at least 14 out of the 20 or so when they received the appropriate shocks. But I agree with you, Ralph. More data will be more probably helpful.
Yeah, I agree. And I think data are coming out already. There was a presentation at the European Heart Society meeting, and they basically did say that those patients who did not survive, who had initially an appropriate shock, had recurrent events either when wearing the device or in the hospital, and often died of some of the complications post-MI, either perforation or recurrent ischemia and infarction. So I think that there are things coming out of there, and like you said, maybe just monitoring patients, such as finding out that they're bradycardic or they're having atrial fibrillation, and then treating them really helps with the dyspnea and just the treatment in general and the treatment of heart failure. And maybe that's what really was the improvement in overall mortality. So interesting trial, very, very much so. Does anyone else have anything to add regarding some other studies that they might have found to be very interesting or clinically useful?
I have 2 comments. One is about the PA pressure sensor remote monitoring study. The concept is very interesting as to what they observed, the investigators observed. The 30% endpoint reduction is quite a significant reduction, the combined endpoint reduction. And I do realize the investigators did propensity matching to be able to have comparable groups. Though the lessons we learned from the CHAMPION trial, which resulted in the FDA approval of the PA pressure sensor indication for NYHA class 3 patients, showed us the following. It's not the device that results in outcome benefit, it's the treatment strategies that are changed, predominantly up titration of the neurohormonal antagonism, not solely the diuretics. So optimization of ACE inhibitors, ARBs, and beta blockers is what conferred the benefit in reduction in hospitalizations in the CHAMPION trial. So just inserting a device by itself does not usually result in a magical improvement. And it then becomes very interesting to think as to which sites were these sites where this data, which is a Medicare claims data, that this data was obtained from, majority of which were academic centers, which actually are following the patients in a very close, very committed fashion. And most of these were actually the CHAMPION sites, the CHAMPION trial sites. So one then comes up with the question of this validates, when done right, when followed and up-titrated in terms of optimization of guideline-directed therapies, tracking the PA pressures and then up-titrating the neurohormonal antagonism will result in a better outcome. The issue is, I think, for the general cardiologists who may not have the infrastructure or the team to monitor these, then I think the appropriate discussions with administrators to create such teams, because I think the key is having the individuals to be able to monitor the patient, intervene, titrate, and then communicate effectively. Insertion of the device by itself will not be adequate. I wanted to emphasize that. And maybe another study that I wanted to mention is the Momentum 3 trial, which is a left ventricular assist device study. And in the ACC, we heard the 2-year results of the Momentum 3, which was the long-term outcomes, comparing HeartMate 3 against HeartMate 2, left ventricular assist device in NYHA class 3B and 4 heart failure patients. This is a very interesting study that has a huge impact on advanced heart failure centers, partly because it validates the findings of the short-term outcomes of the Momentum trial, which demonstrated very similar findings. But just as a background information for our general cardiologist, HeartMate 3 is the magnetically levitated centrifugal flow LVAD. And it does have wide blood passages, and it has no mechanical bearings to create friction, and it has an interesting pulse. Therefore, it's proposed not to have the milieu for pump thrombosis. And in the short-term Momentum 3 trial, it had demonstrated with lower event rate, especially regarding requirement for surgery and pump thrombosis compared to HeartMate 2. In the long-term outcome study, which was presented at the ACC, we again heard that the event-free survival was significantly better with HeartMate 3 compared to HeartMate 2. This now creates the big dilemma of what's going to happen to the practice, whether this is going to push the practice to insertion of HeartMate 3s over HeartMate 2s. But there's a big debate about this because the initial pivotal studies where the HeartMate 2 was compared against older generation devices, the pump thrombosis was not as high as what's being reported in the HeartMate 2 right now in these studies. So in this Momentum 3 trial, the pump thrombosis rate was around 12% with the HeartMate 2, which is the axial device. It was 0% in the HeartMate 3. Now, if we were to look at the historical data with HeartMate 2, the pump thrombosis at the initial study with the FDA approval study was somewhere around 1.6%. So people are debating as to what exactly happened as we are historically looking at the pump thrombosis rates in HeartMate 2, even though they initially were around 1.6, then in 2014 they were reported to be around 8%. Now in this study, it's now 12% in the HeartMate 2, and the HeartMate 3 has 0% pump thrombosis. Of course, now suddenly we're faced with this dilemma of the newer generation device being superior in preventing pump thrombosis, and also the any stroke rates were also lower with the HeartMate 3. Thus, the event-free survival rates were much higher with HeartMate 3, with the centrifugal device. So I think the paradigm has shifted right now in terms of both the safety and the efficacy concept, but I think we need more data. The concept of this device being frictionless or perhaps resulting in lesser loss of the high molecular weight polymers of the von Willebrand factors, which is implicated in GI bleed and or hemorrhagic stroke. Though we understand that the profile of the device is probably better, the GI bleed rates were not different in between the two devices. So